Welcome to the Demonstrating Implementation Excellence stream of the SNOMED CT Expo 2021. My name is Rory Davidson and I'm the Chief Information Officer at SNOMED International, and I'll be moderating today's session. Please use the live Q&A in your AirTouch device to type your questions to the presenter, and all questions will be answered at the conclusion of this presentation. I'm now very pleased to introduce Christophe Gaudet Blavignac from Geneva University Hospital, who will be presenting CoviDB, a SNOMED CT-enabled database for COVID-19 related data. Christophe, please proceed.
Thank you, Rory. Thank you for having me, for allowing me to speak to this SNOMED CT Expo. So I'm Christophe Gaudet Blavignac, as already said, and I will speak to you a bit about what we did in the University Hospital of Geneva on what we call CoviDB, which is a database about COVID. So first of all, the University Hospital of Geneva, what it is a consortium of 8 university hospitals in the state of Geneva in Switzerland. It is the biggest public hospitals in the state of Geneva and the biggest hospital in the state of Geneva per se. It takes care of about 56,000 hospitalized patients by year, 4,000 births, 1 million ambulatory consultations for 300,000 patients per year since a long time. So that's quite a big structure. At least for Switzerland, it's a big structure. And in this structure, there is a small lab, a small division, which is called the Medical Information Science Division, which we call CMED here in Geneva usually, and in which I work under the supervision of Professor, the head and the chief of the division. So the CMED is working around information science, around clinical data and things like that. And we have a few different hubs or different point of expertise in this information science. We use knowledge engineering, symbolic reasoning, algorithms such as machine learning and stuff like that. And we do it for the hospital, for the care providers, for the academic, for the research, and also for some industrial partners. So we are a division that works on data and try to improve care, improve things with the help of data. So it is normal that in a big institution such as University Hospital of Geneva, we have a lot in which we have a lot of workers, a lot of jobs that are working together towards the same goal, which is providing care. All those workers need to share a lot of information, and in fact, even between institutions, there is a need to share information. So you have a lot of people that are sharing a lot of information about patients, about logistics, about everything, and they need to understand each other. That's what we call interoperability usually. And those information, those data of the patient, they are usually stored. We need to store them, so we store them into a lot of databases, a lot of different databases. In fact, into one hospital, you have a database for the electronic health record, in which you have even more smaller database for prescriptions, for formularies, etc. You have a database for the laboratories, for the intensive care units, for the administrative record, etc., etc. And you can have, and that's what we have in Geneva, you can have data lakes in which you put a copy of all this data in it, so you can try to use and reuse those data. So those data, they are primarily used in the hospital to care about patients. That's the main purpose of the hospital. But since we have them, we try to reuse them for other purposes. And this is such as the billing, of course, which is made from the data of the EHR, but also the surveillance, the quality of care, the public health, the research, etc. So this is kind of the nice picture of how everything works and why this hospital is a big, nicely working hospital. But 2 years ago, something happened in the world, and it did not spare the Switzerland, in which it happens also, which was the COVID-19 pandemic. So at some point in March, Geneva said, okay, everybody stay home. So that's the head of this journal, the Tous à la maison, And then we lived through the pandemic like every other country in the world. In Geneva, we had, similarly to other countries in Europe, we had a wave in February, which was very frightening, and we thought it was a big wave. And then in the next winter, there was this huge second wave, which was very challenging for Geneva. And then since then, with the vaccination and the measures and everything, smaller waves. So we lived through that, and the hospital of Geneva was hit also by the pandemic. It was quickly decided in the beginning of 2020 that the public hospital, the HUG, would take care of all the COVID patients in Geneva to kind of centralize the COVID care, and that clinics and private clinics would take care of the rest of the patients of the Geneva. And we see that we had two big waves also in this hospital, with nearly at the point of the first wave, almost 500 patients at the same time in the hospital, it's big for Geneva. And in the second wave, in green, in darker green, you see almost 700 patients with COVID at the same time in the hospital. And if you take also the post-COVID, the people recovering, that's even more. So it was a big shock for Geneva. It was suddenly we needed to use those data and to understand those data. And what we discovered, but as everyone in the world, was that even something as simple as knowing how many COVID patients you have was not an easy question. And all those data, those big data that we stored since a long time, were kind of not easy to use and to navigate when you need to really answer quickly to questions such as how many beds do I need in my intensive care unit, how many patients I have, how many I will have. And it was a problem everywhere in the world, and Switzerland, again, was not different from that regard. So why that? Why it's so difficult, something as simple as the knowing how many COVID patients you have, why we had trouble with that? Simply because in a hospital, the nice picture that I drew at first is a bit different. In an EHR, you have a lot of different information. You have a lot of different types of data that are gathered kind of everywhere, that can be represented in all sorts of manner. So this is just a page of the EHR in Geneva. So you see there is a lot of information, and those information are stored and represented in a lot of different ways. This is just a view on the COVID flag that we used in Geneva. So it's even knowing if your patient is COVID, screen negative, but positive, had a PCR, everything it's kind of complicated. And then it's stored in database and in data lakes, and you need even more knowledge to navigate through that. So it's kind of very a difficult problem. The second challenge that the data poses to us in Geneva, but that's the same, I think, around the world, is that people use different language to speak about the same things. In a hospital, even something as a Centron, which is a drug, acenocumarol, that we give to a lot of patients, it's an anticoagulant, can be discussed by the clinician calling the commercial name of the drug, but if you speak to the pharmacist, he will use the substance name or even maybe an ATC code. And you know, if you are here today, that standards in healthcare are multiple. There is a lot. If you speak about the laboratory that tests this drug, it will be the INR or maybe the internal code of the hospital in which you are. For the logistics, it will be even another code with a barcode. And everything designates the same thing, which is this drug, but under a different view. And finally, for the patient, it will maybe just be the white pill I take in the evening. So it's like looking at the same thing, which is the information, but from a different angle, and you have all those representations. So it's not easy to see everything with the same language. So with all those challenges and the pandemic that was raging in Geneva in February, the Medical Information Science Division was tasked by the governance of the hospital to kind of help them navigate through this big storm, which was the COVID. So the idea was to create a database of all the patients, of all the COVID patients at the HUG, to support the decision process of the governance. So to help them to have a compass to say, okay, what we will do, how many beds we will need tomorrow, what to kind of predict the evolution of the epidemic at each point, to follow this big event and to each time predict what would happen in 2 days, in 3 days. And then we'll host those data that would be gathered to reuse them under all the restriction and the regulation that apply on research, such as general consent, IRB, etc. But to allow the reuse of those data for research, since we would have them. So we started to do that, of course. We stopped, in fact, in February 2020, the CMED stopped everything that it did to focus on COVID. So we started to work very hard on that. And we decided to create this database, which we called then CoviDB, with 3 main axioms, with 3 main rules. The first one being focusing on existing data, so not try to represent or to modelize something that we don't have in our database instantiated. So not take every disease, every labs, but just focus on what we have, on what exists one time in the database. So to reduce the noise with this approach, to create human readable label for those data, because the clinician or the head of the hospital needs to understand the data. We cannot say to him, this is an ETC code. It means you have to know ETC, you have to know the internal code of HHA. So to give human readable label, French, because we are in a French speaking hospital, and then to ground the semantic of the data using SNOMED CT. So to encode this with the global language of healthcare, of course, to allow semantic interoperability of this data, to allow better query on this data, and to ground the semantic of it. So that's what we started to do. We took all patients very broadly that were related to COVID-19. So all patients that were either tested, positive or negative, that were diagnosed with COVID, that were suspect of COVID, everything. We put this big set of, this inclusive set of patients. We took for them all the structured data that we had in the hospital. So laboratories, observation, diagnosis, prescription, things like that. And we took 2 years of history to have the story of the patient. If the hospital knows him, we took 2 years of historical data for each of those patients. Then we took the raw data, and this is an example of the data we have for the blood pressure. And we did what we propose in our approach. We created readable label in French. So anyone who navigates into the database can understand what he sees. And we encoded it with SNOMED CT codes to have this very big knowledge and structure that SNOMED CT gives, and that we can exploit later to query the database and compare information. So in the end, the result of that was a big database in which we have encoded and simplified and encoded in SNOMED more than 4,000 lab analyses, almost 400 observations, and 128 formularies and other data. Just an example in which we simplified, as you can see here, with all the lab about COVID, with the simplified label and the SNOMED CT encoding to kind of give a usable view of those data. So this was the encoding part, the clear label and encoding part. And currently, this database is now working in HG. It's updated every day. Every day we take the differential data from the hospital and we process it. And each time there is a new analysis that appears in our data, we encode it. And this is a database that contains about 200,000 patients, 30 million analyses, 4 million diagnoses. I won't cite every numbers, but for about almost 1 million hospitalization that answer to those criteria. So it's a quite big database that we use. Oh, sorry, I missed the animation. That we use to create first the those prediction and those graphs that we gave to the governance of the hospital to help them in their decision. In fact, we created a full dashboard website that they can use, but I cannot show here because it's of course for their private use only. But we created from that a lot of visualization. We integrated new sources of public health data, and we created a nice dashboard that the governance can use to decide and see how it goes in Geneva. And this database is now that the pandemic is more calm, is used under general consent and IRB approval, is used to extract data for research for a multiple project around COVID that we can nicely extract, because we don't need to know the full structure of the Hospital of Geneva, of their database, to understand and to extract data. So in conclusion, this is what we did, a database of all COVID-related data in the University Hospital of Geneva, gathered in one place with a clear semantic, human-readable labels, and only focusing on relevant items, on what exists. We don't have the codes, and we don't modelize what we don't use, and benefiting from all what can bring SNOMED when you have data represented in SNOMED, so the expression concept language and things like that we can exploit to better navigate and dig into those data. So thank you very much, and I'm open for questions.
Hi. Well, thanks very much, Christophe. Fascinating presentation. Really interesting, very timely. It's the world we've been living in, but I think it's fascinating to see these types of solutions coming out. Whilst we wait for some questions, just to let people know that to ask questions, please click on the little AirTouch app you see somewhere in your screen at the bottom corner, and that's where it'll pop up and it'll allow you to ask questions, and I'll answer and I'll pass them on to Christophe. Whilst we wait for some questions to come through, a couple of questions from myself. Being a technologist, I'm curious about what technologies did you use in the CoviDB?
In fact, we use multiple. So hi, because
Yes.
it was me before, and now it's me now.
No, different clothes,
but the same shirt. Yeah. So hi, Rory, and thank you for having me. In fact, the technology changed along the way, because, as I said, this project is in fact something that is kind of was organically grown since the beginning of the pandemic, because at some point on a Sunday, our chef called us and said, okay, everyone is at home beginning Monday, who is okay to work on COVID now? so we started to work on COVID, and rapidly the need for a database that was focusing on those data and solving those problems was apparent. So we started very simply by grabbing the data from the data warehouse, which is a NoSQL database, which is very difficult to manage to query. It's long, it's not very suitable for quick analysis of data. And we, at first, I think we used some kind of SQL relational database in which we quickly put data. It was not much patient, because at first it was not the thousands of patients that we have now. And it was some SQL relational database such as MariaDB or MySQL. Then we changed for a more warehouse-oriented solution, which is called MonetDB, which is another free open source database that is very good to have quick query on large data, but it's still a relational database. And this could change with the time, because what is not apparent in my presentation is that this project and this way of gathering and encoding the data was picked up and appreciated by the hospital, and it grew into a support from the hospital to create a research database for the whole hospital. So we are now tasked with the challenge of building this, but not just for COVID patients. And for that, we will need to change probably the system. And we could go to, we look into graph databases, which could have some advantages, very important advantages, because it's not as constricted as a national database, but we basically focus on something that works. We don't have a religion about that. Currently, it's MoneyDB, I think, which is still working and still growing, and it's good for quick queries. But if we want to include more data and to maybe produce SNOMED easy to query with SNOMED, we should migrate to something new.
Okay. Now,
so I think we have a question.
Yeah, I've got a question from Francois. So what specific... Yes, hi Francois. What specific hierarchies were mostly involved in encoding the data in the database, beside findings, of course?
So beside findings, it was... sorry, I reread the question.
So yeah, which hierarchy is used?
In SNOMED. So basically, we were focused on the type of data that we encoded. So for the laboratory values, we used mainly procedures, but also finding, because it's not easy in SNOMED always to find all the labs in one or in another. So we kind of go back and forth between those. For prescription, we use the drug, the substance hierarchy. For the observation, it was findings like pulse, etc. And what did we use? A few other codes to modelize, like inpatient stays and maybe intensive care type of care. So it was very... we didn't focus on some hierarchy. We focus on the data. We use clinicians like myself and a few colleagues that know SNOMED CT, and we try to represent in the best way the data with SNOMED CT. But that was the main, from the top of my head, the main hierarchy that we used.
Okay, thank you. I've got a question from Darren. Hi, Christophe. Thanks for the presentation. Does the database support different versions of SNOMED CT? And also, is it easy to upgrade the versions of SNOMED CT that have been used?
That's a good question. Right now, it uses one version of SNOMED CT, which is, I think, the July version of 2020, which is the one with COVID added in February, because obviously we needed those informations. Currently, we don't have really a procedure to migrate those encodings, but it is something that we will have to look, but was not strictly necessary at first. The idea was to quickly be able to answer a question, but we think about how to provide this update of the mappings, because the database will not change much with the version of SNOMED, but the encoding will. And this is, I think, a challenge that we haven't really scratched yet, but we will need quickly to do, because I think everyone is confronting to that.
Yeah. So I've got a few questions myself, just follow on from some of those questions. So, I mean, you talked about technology you use. Did you look at using a terminology server, like maybe a FHIR terminology server in the mix as well, to help maybe migrate do some migrations around versions of SNOMED CT?
No, right now we don't use a FHIR terminology server. We use, of course, the Snowstorm server, which is provided by ITSDO, by SNOMED International, because it's the easiest way to be able to search SNOMED from yourself without using external, because we are in a hospital and everything has to be internal. And so we have a Snowstorm instance that we use to encode and to query, basically, but no FHIR repository at the moment. But it could evolve if we see about solutions such as OMUP or Odyssey, which is this big solution. They include no, not the solution. Sorry, but we look into another solution for clinical research data, which include a FHIR repository in it, but we didn't add it to CoviDB right now.
Okay. No, thanks very much. And so thinking, yeah, as you mentioned there, that you worked very much within the scope of the hospital. Do you see that this might expand across multiple organizations at some point? Digesting information from other sources as well?
I think it's a very good question. As you said, it's very internal work, because the question that we needed to answer was internal question, like how many patients do I have now? And you ask 3 people in the hospital and you have 3 answers. And this was very, very targeted to that. But the problem that we needed to solve are universal. It's still in 2021, even with SNOMED CT and a lot of efforts, those issues that I explained at the beginning are still there. And if you look into, I think, even the most digitalized hospital, you have those multiple terminology, multiple language, multiple database, because it's a big structure. So the idea that we want to push really, and that is expandable, is the vision that you don't need to learn to everyone to speak SNOMED, because you won't. Nurses will use their nurses terminology, clinicians will use their clinician terminology, because it's made for them and it's their use. But SNOMED has to become this link. I often use the Esperanto analogy, except in a successful way. But SNOMED it's like an Esperanto. It's a language that can be understood that can represent everything for everyone. But the good thing is that, unlike Esperanto, you don't need to learn every people to speak in Esperanto, but you need to store your data with this semantic, because it's the only way to respect every usage, every terminology, but to gather them in a way that you can compare. And you can ask in your database, I want every patient that had a nosebleed. And you don't need to say, how does the nurse say nosebleed? How does the clinician say nosebleed? How does the surgeon say nosebleed? And this is really the vision that we push strongly in HUG, and that I think is expandable and should be expanded.
No, great. That's useful to know.
I think it's aligned with the goal of SNOMED CT. So.
Yes, absolutely. And I think that's where, as you say, SNOMED CT plays into that type of scenario of a single way of representing different people's approaches to some of these angles, these things. So, with the time that's left, I've got a final question, which is always a good question when you spend months and months working hard. What would you do differently now you've learned? I mean, what have you learned in this process? And if you had to go back to the beginning of the thing, what would you do differently?
I mean, maybe I wouldn't do very differently, but that would have been a huge gain of time if we redo the encoding. Because, when you start to say, okay, we will convert all that in SNOMED CT, and that wasn't done, so you have to start. Even if you know SNOMED, even if you encounter things that you didn't think of. And this is an experience that is so valuable and so important that at first you do it and you arrive at the end of the lab encoding, and there is like 4,000 labs. It's not very long. You can do it manually, but you arrive at the end and you say, okay, I should have done these things differently from the beginning. And this is maybe impossible to do differently, but each time you re-look at your mapping, you do better. So this this is something that you learn doing it. But doing differently, I mean, it was all done in emergency, so it's hard to think about doing it differently.
Yeah, of course. Well, great. Well, thank you very much for answering the questions. Thank you very much for the questions we got from the crowd. Look forward to hearing more about the next iterations of CoviDB. Or you'll need to change the name from CoviDB to something different if it's not just COVID. So thank you very much.
Thank you very much, Roy.
Thank you.
Thank you, everyone.
Thank you.